Hi, everybody. Thanks for having me. So I recognize some names on here too, which is fun, always fun for me. One of my highlights most years is coming out to Montana. We've done a number of screening events out there, and I'm usually at that Montana Diabetes Conference, but it coincided with other things this year. So I'm really happy to be here. I myself was a school nurse. My mom is a retired school nurse, so I don't work in school nursing full time anymore, but school nursing is held very close to my heart. But what I do now is I am a clinical research nurse. I picked this job up over a summer of school nursing, and have stayed here. I've just fallen in love with the people and the patients that I work with. So I work with families, adults, kids who are on their way to being diagnosed with type 1 diabetes. They're antibody positive, so I do a lot of education before somebody needs insulin, as well as working with people who are newly diagnosed and going through clinical trials here that we're looking at. So I'm going to talk a little bit about what that research looks like, and then kind of look at what it might look like in the school setting, and hope for the future. So I'm really bad at monitoring the chat as we go along. So Kate is going to help me out with that. I am definitely an interact educator. So if you want to unmute and shout out and answer when I ask a question, please do. It's just way more fun for me. So the objectives of this talk today, and I know it's pretty short, but I'm going to try to kind of give a brief overview of what type 1 diabetes is and who it affects. I know this is review for a lot of people, but even as nurses, if we're not seeing it all the time, we forget pretty easily. So we'll go over that. And I want to talk about the tools that we use nowadays to screen people for their risk of type 1 diabetes before diagnosis. I want to talk about disease-modifying therapy is what what our research is looking at and its use in type 1 diabetes, and then kind of exploring what the disease-modifying therapies might look like for the school setting or for an individual that hopefully one day is receiving them. So let's start with the 101. We have all the cells in the human body, right? We've got our brain cells, our muscle cells, all of our cells, our tissues, and they all need energy to function. Where do we get that energy? Somebody tell me. What do we use for energy?
Sugar.
Sugar. Thank you. Yes, sugar. Glucose. I use those terms interchangeably. So this big old molecule here. And somebody already said it. I usually ask, where do we get sugar from? The good stuff, the food, right? Primarily carbohydrates breaks down into glucose in the blood. We also are always making glucose in the liver, and we're storing it there as well. And so glucose travels through the bloodstream all the time, going to the cells that need it. Okay. So what is insulin? What is this thing?
The gatekeeper for sugar.
Yeah, I put it on the screen to help you out. Yeah. It is. It's a hormone made in the pancreas, right? And it acts like a key to open up the doors, right? So we have all these big purple blobs or cells. They all have these doors with keyholes on them. And then we have sugar floating around here in the bloodstream. And the only way for that sugar to get into those cells is with that insulin or with a key. So it's made in the pancreas all the time. It's made and it's when the glucose is going up. So in somebody without type 1 diabetes, they have this kind of natural regulation and natural balance. Okay, but it's happening 24/7. Okay, so like I said, we're always balancing. So what does it look like to be balanced, right? So we have what we call target range, which could be a whole talk on its own when we talk now about target range. And that's typically somewhere between 70 and 180. This is this nice amount of sugar that floats around ready to be used by the tissues, right? It's not too much. When there's too much, it gets very viscous, and it's not too little up there. So you'll hear target range a lot more nowadays with people who are wearing continuous glucose monitors because we try to keep our glucose in that target range of 70 to 180 as much as possible. So low blood sugar under 70, the cells can't really function, right? The cells are starving. And in high blood sugar, the blood is really oversaturated. It actually kind of turns into, say, like a syrupy type of liquid. It can be really thick. Okay. So let's come back into the clinical space. This is one of our providers here. So when somebody is newly diagnosed with type 1 diabetes, we say, hi, you have type 1 diabetes. And oftentimes we get this question of, what did we do wrong? And we answer with, it's autoimmune, right? You did nothing wrong. What does it mean when something's autoimmune, right? So we have the cells in the pancreas, right? These beta cells. My arrow's on the wrong one. These beta cells, these are what make insulin, right? They're the little key producers in our key factory of the pancreas. And we also have our immune system, right? We have T cells, and those are there to typically fight infection, right? They're there to fight off bacteria, viruses, and keep us safe and healthy. So these T cells are usually really good. They're good guys, right? In type 1 diabetes, those T cells are attacking beta cells as if they're foreign. So they misread, something's being misread there, and they go after those cells that are producing insulin. So by the time someone is diagnosed, a lot of these beta cells, or these cells that make insulin, aren't functioning. Less than 20% are functioning when somebody is diagnosed with type 1 diabetes. When we see that A1C go up, maybe they're in DKA, we see elevated glucose. The T cells have really done their damage.
May I ask a quick question?
Yeah.
Earlier you mentioned something about like an antigen test.
Yes, we're going to get to it.
Thank you.
Yes. I'm happy you're excited about that. That's kind of the point though, right? So we are diagnosing people when less than 20% of their beta cells are left. Could we do it earlier, right? We often get asked that. So I wish we had these superpower eyes to look into somebody's pancreas and say, oh, look, it's the beta cells are being attacked. We don't have that. So we have these other ways to tell. So one of the things I didn't mention in this immune attack are the B cells. So we have B cells, also immune cells, that are used to show our T cells what to go after, okay? And in type 1 diabetes, the B cells are kind of to blame here. They're sending the wrong messages to these T cells and sending them out to go attack the beta cells in the islets, okay? So what do you think these markers are called? You said antigens, so that's very close.
Antibody.
Antibodies, yep. So these are antibodies. They're found in the bloodstream, floating around, and those can be checked with a blood test. Okay, so we've heard a lot about antibodies since COVID, right? They've gotten some attention as a useful way to check for an immune response. So in type 1 diabetes, we know of 5 autoantibodies that are associated with this immune attack. Okay, there might be more that we haven't discovered yet, but right now these are the 5 that we look for. We also know from TrialNet data over the past 20 years that 95% of children who will develop type 1 before puberty have autoantibodies by the age of 5. So we can see this years before somebody needs insulin, right? This is really, really beneficial when it comes to the clinical world as well as the school world, right? So when somebody does test positive for 2 of those 5 autoantibodies, they have almost 100% chance of developing type 1 diabetes over the course of their lifetime. That rate of progression does vary, but we have been able to start staging type 1 diabetes because of this knowledge, right? So this is what we call the stages of type 1 diabetes, and this has really been kind of adopted into the clinical world in the last decade. So we know there's a genetic risk associated with type 1, some kind of immune activation that we haven't identified yet, and then this immune response or the development of a single autoantibody. That is not where we stage diabetes, though. The stages begin when there are 2 or more, okay? Because we know most people with 2 or more will eventually need insulin, right? So stage 1 is 2 or more autoantibodies, but the blood glucose is normal. So if you think about this like a candle, right? You have the beta cells in the pancreas, and a flame is lit with this immune response, okay? And it's a little gray area because one autoantibody, we don't stage it. Only about 20% of people with one will progress to stage 3. So this flame can go in or out at immune response. But when we're in stage 1, the wax has started to melt, okay? Though the blood sugar will be normal. So you wouldn't see this. This wouldn't be diagnosable from a primary care physician. You wouldn't see an elevated A1C. Even on our glucose tolerance tests that we do with people in stage 1, their blood sugar, they're having a large amount of sugar in these glucose tolerance tests, and their blood sugar will stay totally normal, okay? Stage 2 is when we start to have some abnormalities to the glucose on those glucose tolerance tests. So they drink a sugary drink in our clinic, we check their blood sugar every 30 minutes, and we start to see some rise to their glucose, but they're still not in the diagnosable range. Again, a PCP or a doctor would probably not pick up on this at that point, okay? And stage 3 is when we've killed off, the immune system, not us, has killed off enough of the beta cells that the wax is really diminished, and it's diagnosable. So the A1C is elevated, there might be symptoms, and the glucose, they need insulin for treatment typically. The progression is age dependent. So we do know that the younger someone is with autoantibodies, the faster they move through these stages. Okay, we see people in adulthood with 2 or more autoantibodies that will go many years without progressing through the stages. So stepping back, who is affected by type 1 diabetes? It's a lot of things that we can do to prevent it. Who do we target? Who do we watch for this? The numbers in the US, about 1.7 million Americans we know have type 1 diabetes. 304,000 of those are pediatrics, and 18,000 under 20 years old are diagnosed every year. We do also know that about 50% of new diagnoses now are adults. So really important to watch for adults who are often diagnosed with type 2 when they actually have adult onset type 1 or autoimmune diabetes. My Montana statistics they were hard to find. So I am weary on them, but what I did find was that about 7,500 residents in Montana have type 1 diabetes, 1,600 of them children and adolescents, and about 500 new cases every year. This is hard data to find, and I'll emphasize that. I know that your group is looking at trying to track this better in the state of Montana, which is awesome. The incidence is going up every year. So if you don't have a student at school with type 1, you probably will at some point in your school career, okay? So when we talk about who is affected by this autoimmune process, I did mention this kind of genetic piece to it. The general population risk is about 1 in 300, okay? So 1 out of 300 people will develop type 1 diabetes at this point, okay? Now, we do know from screening family members and watching people progress from having multiple autoantibodies to type 1 diabetes that family members, the risk goes down to 1 to 20, right? So 15 times greater risk of developing type 1 diabetes when you have a family member that has it. Okay. So let's talk a little bit about screening. For those autoantibodies, one of our kind of options is to screen, right? To check for autoantibodies before somebody is developing stage 3 type 1 diabetes. TrialNet is available. This is the study that it's a study for family members that's been around for about 20 years, just over 20 years. And first degree and second degree family members can screen for free within these age ranges. Or if they don't have a family member, but for some, you have positive results outside of TrialNet. And there's a number of ways to do this. You can order a kit online. There's a finger stick kit that can be done at home, or they can go to a screening event, which we have done in Montana before. There's a number of options there. So I do ask that you talk to family members if you have the opportunity to tell them that their family members can be screened for free. This is really important for them to find out and really huge for our research to help us understand why people are getting it.
May I ask a question?
Go for it. Yeah. No, thanks.
So what is your understanding about risk factors for type 1 diabetes in families that have other autoimmune diseases, but not 1 diabetes?
Yeah.
Just as an example, I have a freshman and a junior that both have diabetes, and there's like type 1, and there's no one in their family that has type 1, but they have a lot of just autoimmune stuff.
Yes, we see it all.
I'll leave it stuff,
We see it all the time. We often know, and not just type 1 diabetes, but that autoimmune diseases, they like to travel in a group, right? That many people who are diagnosed with one are diagnosed with more than one.
Would this still not kind of provide free testing for?
Correct. Yeah, it not TrialNet, but I do have a slide I think I have the slide in here. There are options if you don't have a family member to still get screening done. Yeah. But it's a good question. And I don't have numbers on it. I do wish that I did. I could probably dig in TrialNet vaults to find a statistic on the risk of type 1 diabetes with other autoimmune diseases, but I don't have that on my top of my head.
And also, follow-up question, do you have a slide coming up on like suspicions for that trigger?
For the antibodies?
Yeah.
Or for diagnosis?
For what triggers the
immune response?
Yes, what triggers the immune response?
There's still a lot of research on that. We don't have an answer. There's a lot of looking. I'm just going to answer. I don't have a slide on it, but there's a lot of looking at viral triggers, right? There's been a lot of looking at the GI viruses. We know that celiac is often associated with type 1 diabetes, and looking at the biome. A lot of research on the biome. I don't have an answer though. Yeah, I wish. If we knew, we would do a lot more things out there to prevent it. Still working on it. So the Pathway to Prevention study, this is what offers the screening for people with type 1 diabetes for family members. If they're negative, they can rescreen until they turn 18. We do offer monitoring for people who are in stage 1 or 2. Where we're offering glucose tolerance tests every 6 months. So we start to watch for the development of type 1 diabetes so that we can diagnose as early as possible. We're monitoring A1C. And then, like I mentioned before, they get extra support. We get to talk through it before somebody is diagnosed. And then TrialNet has a number of prevention trials and new onset trials. And that I'll talk about a little bit more. So, so before this, no one in our family had type 1 diabetes. This is back to Kate's question, actually. Can someone without a family history of type 1 be screened? So we actually know that 85% of people do not have a family history, right? There are a few options for them. We know about the ASK study. So there's a study out of Colorado. This is another free test. It's an at-home kit. If they are multiple antibody positive, they do monitoring with CGM. They'll send them a CGM to do that. And it's all ages, and you don't have to have a family member. And then there are options for having a healthcare provider order those labs for you. So I would recommend going to the Breakthrough T1D website. They list the CPT codes and the tests that you can ask for your provider to order. So back to like the research side. where do we intervene? Now that we're familiar with these stages, that we know this happens early on, where can we intervene to keep this candle and prevent the destruction of these cells that we so want to keep, right? So we talk a lot in diabetes about a cure. I've been told, I know Tanya's heard that there would be a cure in your lifetime, right? We all want this cure. And so I like to kind of cover this idea that there are kind of two options to how we would quote unquote cure the disease. And really none of them are removing the disease process, but affecting it in a way that makes it less burdensome. So we can replace the organ, right? There are these closed loop systems where there's a lot of talk about transplant and stem cell transplant, stem cell derived beta cells. You see a lot in the news about those. And what we focus on in TrialNet and here at Benaroya is changing that immune process by inducing what's called immune tolerance, retraining the immune system, and interrupting how it's signaling. And that's what I mean when we talk about disease-modifying therapy. It's changing the way the immune system is working so that it does not attack these cells that we need. Why do we need this? We know technology is advancing. I get this question a lot. We've got insulin pumps that talk to the CGM. Diabetes is, there's better and better technology. And boy, I wear a pump. I agree wholeheartedly. The reality, though, is that even with all of this, diabetes is still hard, right? These graphs that you see on here have the red line of our target A1C of 7. And these graphs are people on, this one's for MDI and pump users. This one's for CGM or blood glucose check users. And none of them in this age range are meeting the A1C targets. And so it's still hard, it's still burdensome, the lifespan is still shortened, and unfortunately the technology doesn't really affect the immune attack that's happening. So we do know that immunotherapy is effective in autoimmune disease. This is an example that I stole from a slide that I stole from one of our providers here. This is a picture of juvenile rheumatoid arthritis or juvenile idiopathic arthritis, JIA. And for many, many years, this disease was really debilitating. Kids were wheelchair bound. Similar to diabetes, we had JIA camps, and kids had to really get a lot of accommodations in school to do these activities. And it's now kind of the standard to get an immunotherapy to treat this, and kids are living very normal, active lives that they could not have lived before the immunotherapies. So in type 1 diabetes, we know that there are at least 8 immunomodulatory therapies that have been effective in preserving that function of the beta cells. The research has primarily looked at new onset type 1 diabetes, and these are listed here are the ones that have been effective without side effects that prohibit the use. Okay? And so this is where they work. And I'm not going to go into too much detail, but this really just gives you an idea of how complex the immune attack is, right? There's a lot of signaling. We see our B cells here. Our T cells are over here attacking. There's a lot of communication that goes on between these cells to produce this attack on the islet cell. And so these medications that have been looked at are looking at where can we safely intervene that communication to stop this from happening. Has anybody on here heard of Tzield, teplizumab? Yeah, shaking it. Tanya has. So Tzield was a TrialNet study. It's a medication that was FDA approved in people with stage 2 to delay the progression from stage 2 type 1 diabetes to stage 3 back in 2022. So this was a huge game changer for type 1 diabetes. It was a TrialNet study. The data that we have so far is that there's an average of a 3-year delay in that progression from stage 2 to stage 3 where somebody needs insulin. So it wasn't perfect, right? This was the only study to ever statistically demonstrate that the progression can be delayed. It was the first immunotherapy to ever be approved to prevent autoimmune condition. But it didn't work for 100% of participants. It worked for enough, but not for everyone. So there's more work to be done as far as exploring these other ways of intervening the immune system and how to get one medication to work for an individual. So the takeaways I have on this part is that type 1 diabetes is autoimmune. Always remember that. It wasn't because the kid ate too much sugar. It's funny how we still get that, though. Family members are 15 times more likely to develop type 1 diabetes. Okay? Type 1 diabetes starts when there are 2 or more autoantibodies. It does not start when someone goes into DKA. This starts sometimes years before that. The rate of the progression is age dependent. So the younger one is, the faster they progress. And risk screening is free for family members of the eligible age through TrialNet, as well as other ways that they can screen. And we know that disease-modifying therapies have shown successful in preserving beta cell function and preventing stage 3. So now the last part of this is the school part, right? Lastly, and most importantly, our family says, what does this mean for our school nurse? And I love Dr. Laura dearly, but she has no idea. So she would say, I'll have to ask Anna. So from my experience working in the school, I will at first like to kind of think about our hope if we had all of our kids with type 1 diabetes on disease-modifying therapies that they would barely need a school nurse, right? Their body would be producing insulin. They wouldn't have low blood sugar anymore. You barely need a care plan. I would love that to be the case. So that is my hope one day. But really the possibilities that exist are something like this, right? Where the families might know that type 1 diabetes is coming. They might not want to know and not want to talk about the risk. But there can be some awareness and anxiety around it. There can be helpful to do some early staff education, but I'd be careful not to go over the top with it. You don't want to freak anybody out. They don't have type 1 diabetes at this point. They don't need a care plan yet, but it is helpful to watch for symptoms, right? The subtle symptoms. If you know somebody is in stage 1 or stage 2, those are something to act on, right? They might be missing school. These therapies are given as infusions or they're given as injections. They do require monitoring, especially during a clinical trial. And for the FDA-approved treatment, it's 2 weeks of infusions. So they might be out of school for a little bit. There might be multiple family members at school with type 1. So not surprising there. But this is what the extended honeymoon might look like, right? They might not use very much insulin. They might have phases where they come off of insulin. They might be using technology off-label. I have a student on an Omnipod who's still making a ton of insulin who uses like 5 units of insulin a day in their pod, right? And the pod is only FDA approved for 8 or more units a day. So you might be seeing that, right? You might be seeing them fight for a CGM because they're not on very much insulin or insulin at all. And there's easier recoveries from lows. So when we maintain this beta cell function or this ability to make insulin, we have the ability to prevent the low blood sugars as well. Our glucagon regulation is much better. So our needs for families in school, we really just hope people talk about us, refer families. I don't care if they know what they're asking or if they're just heard about us. We're here to answer all questions, whether people are eligible or not. Families often don't know that their family members may be at risk or that screening is free. They also need help. I often like to remind people that progress in research is being made. I didn't believe it. I was told there would be a cure in my lifetime. I didn't believe it. And then I came to work here and realized I've been here for 9 years that progress is always happening. So there are options, and please contact us anytime.
So my name is Tanya Furman. I am the founder and executive director of Montana Youth Diabetes Alliance. We are a grassroots nonprofit here in Montana that fills the unmet needs that our youth and families have with living with type 1. We do many things. Obviously, as I've talked to you before, we put on a camp for kids ages 8 to 17. We have a family retreat every March, which brings in both the adult and the youth part of conjoining families in collaboration with Type 1. And then we do help families or kids, I say kids up to the age of 24, with out-of-pocket expenses. So if you have a family that is struggling to pay for self-management supplies for their diabetes, whether it be a diabetic bag or one of those coolers to keep their insulin cool, different things like that, you can have them go onto our website and they can fill out a form, no financials required, and we can help them up to $500 per kid per year. Please note that unfortunately, at this time, school nurses can't apply for those to get like low treatments or anything like that. It's strictly for an individual request. However, with that, we did launch a new community outreach program in trying to get more support for those school nurses. The dish session we did last year, our big concern was, how do we help you? How do we take this burden off of you, or the burden off the family or the child? And with that, we have created totes. Order in here. So these totes include our logo, our website, and then who the tote is assigned to. And then on the flip side, we have an index card that includes the name of the student, the grade, the teacher, the low treatment strategies, yearly review of their 504 plan, and emergency contact information, and other. And so one really important, exciting piece for us on this is making sure that those 504 plans are in place. And we want to, I'll get into that in a little bit, but these will be full of juices and snacks and crackers and different items for them for a low treatment tote. Our goal is to get each kid with diabetes in each school one of these totes. I will be at the school nurses convention next week, and hopefully we'll have a ton of these to be able to give out. But that 504 plan, in keeping these filled, I'm losing track, we're going to provide resources. So to keep these full, we understand, there are school nurses out there that take money out of their own pocket, and it takes up to a year to get reimbursed. But there are other options. And obviously, Kate sharing the slide, many local grocery stores are all about supporting schools, and especially hunger in schools. And this is one of those things that they would be more willing to support. So although we are initially filling these, it is the school nurse's responsibility to keep them full. I am also researching possibilities for other grant opportunities and the possibility of, if need be, we just send you a gift card. So that might be a nice option as well for you to go out and purchase. In regards to that, as well as far as resources, 504 plans, we want to ensure that school nurses and admin know what those are and what they entail, to ask the questions, is the care plan truly set for this child? Is it 2 pages? Is it 13 pages? And be able to provide resources to school nurses and that impact as well. So, and we, oh yes, these are bigger grants. So we do have a few school nurses out there that have requested bigger grants and actually even support sending their kids to camp, not just keeping their totes filled. So that'll be available as well. Did I have any more slides?
Yeah, when I send out information about this afterwards too, all of these will be clickable links, so you guys can go directly to the grant applications as well.
And then, yes, the other exciting thing MYDA has launched is community outreach, is getting families together in their own communities. So MYDA doesn't have the bandwidth to necessarily go to each town and put on a little event. So we are asking our school nurses, our parents, community organizers to organize their own event, but MYDA will market and monetarily help fund it. So as an example, in Victor and Stevensville, they're going to do a pumpkin carving contest, and it's for all free to all type 1 diabetic families and their family members. Other examples would be bowling. Helena has the carousel. If you wanted to do a picnic and you wanted us to provide, picnic items, there's, whatever is exciting and fun in your area that you think you can get families together just to collaborate. I think this is a great way. So on our website, Teresa's the coordinator for this. It goes to a committee. We look it over, and then we let you know within 1 to 2 days what we can do to help.